Hello, you beautiful people. Welcome back. Today's dissection is number 24. This will be a difficult dissection for you today, and it will require you to do some self-talk prior to coming to lab to prepare yourself. Today we will be bisecting the head right down the middle in a mid-sagittal plane, which even talking about it just sounds shocking, I'm sure. But remember, I want you to remember that these donors have decided themselves to make their bodies available for you and people like you to learn about the body, the human form, in an effort to be helpful and meaningful to the medical field. They have made this decision fully aware that their bodies would be completely dissected for the sake of this type of learning, and they are in favor of what you're doing. This is not something that they wouldn't want you to do. That said, it still is going to be difficult to perform just mentally. You have to kind of get your head around this one a little bit. I didn't mean to say it that way, but now that I said it, it's out there. Anyway. Okay, so here's what we're going to do. We're going to start today with a little review because that's always helpful, I think. We're going to talk about the infratemporal fossa. This is going to be a review here. So this is the portion below the temporal bone, right through here. We've removed a portion of the mandible. The ramus is gone at this point in order to see this portion of the body, of the skull that we're talking about right now. And the medial and lateral pterygoid muscles are right here. Here's the lateral pterygoid muscle. Here's the medial pterygoid muscle. These both help to pull the jaw forward or protrude the jaw. The medial pterygoid will also be involved more with elevating the jaw than the lateral pterygoid. Clinically, I see these, the lateral pterygoid, I dry needle quite a bit with TMD, temporal mandibular dysfunction. This muscle seems to, once it releases, it seems to release the pressure on the condylar process and the articular disc and provide some significant relief. But that's just an aside on that lateral pterygoid. The mandibular division of cranial nerve number 5 is a major feature in this area. So it comes through the foramen ovale in the infratemporal fossa up into here. A couple of nerves that we've seen already, the lingual nerve coming right down here to come into the tongue. This is a sensory nerve to the tongue, not a motor nerve to the tongue. The chorda tympani, this is a big, not a big nerve, but it's an important nerve because it actually comes from the facial nerve. Here's the facial nerve exiting the stylomastoid foramen. Here's a different shot of that facial nerve exiting the stylomastoid foramen here. And so the chorda tympani is actually a branch. You can see it right here coming off of the facial nerve. Next to that tympanic membrane coming across and then joining up with the lingual nerve from the mandibular division of the trigeminal here. So you can see the chorda tympani coming down this way. The chorda tympani is going to exit right here into the petrotympanic fissure on the back side of the mandibular fossa. And it is actually, as it joins with the facial nerve here, coming down to provide sensation to the anterior two-thirds of the tongue, it's actually what allows the facial nerve to be a mixed nerve, both motor and sensory. Remember the facial nerve giving all those branches coming out from underneath that parotid gland, giving those branches coming down this way towards the temporal, down to the cervical regions, giving mostly muscles of facial expression, motor control to those muscles of facial expression. But it's a mixed nerve because of the chorda tympani, which sneaks down here and attaches to that lingual coming down this way. I think that's kind of interesting. Okay, the inferior alveolar nerve runs parallel to the lingual nerve right here. You can see it's been cut. It would enter that mandibular foramen inside the ramus of the mandible that we've removed. It travels within the mandible, if you can kind of imagine it coming down here. Here you can see it's still within the mandible, so the inferior alveolar coming down this way. And then it will exit the mandible via the mental foramen as the mental nerve right here on the chin, giving sensation over that area. But as it travels within the mandible, it'll supply the teeth and the jaw with sensation there. We talked about the dental work being done in a previous lecture towards injecting near that mandibular foramen to get the inferior alveolar nerve numb. Here you'll also see on this slide here, there's a submandibular gland. This is a parasympathetic gland suspended from the suspended from the submandibular gland, there's a parasympathetic ganglion right here in the lower part of the oral cavity. We won't see this much today, but we will. We may find this in a future dissection as we investigate the oral cavity a bit more. On this same slide, we can also see the inferior alveolar nerve right through here as it comes up. It kind of loops. I'm sorry, that's the auriculotemporal. Here's the off of that inferior alveolar as well. Sorry about that. Is going to be this nerve to the mylohyoid right here. That's going to be a branch. You can see it jumping off that inferior alveolar here, coming down across that submandibular gland and innervating the mylohyoid muscle. Here you can see that little branch diving down to also innervate the anterior belly of the digastric muscle right here. Is there. Now back to the auriculotemporal. Sorry, I got a little confused there. The auriculotemporal nerve comes off of again that mandibular branch of trigeminal, and it comes kind of loops backwards and comes up just in front of the ear and provides sensation onto the side of the scalp and in front of the ear. It'll also give some innervation to the ear itself, right up into here. The buccal branch, you can see this one coming down onto the cheek here for sensation onto the cheek. This is going to be a bit difficult to differentiate between the buccal branch from the facial nerve. But remember, we talked about the facial nerves coming out of the parotid gland. The buccal nerve, this branch of the trigeminal, is actually going to come out in front of the parotid gland and under the masseter muscle. So that'll be a differentiating factor between the buccal branch of the facial and the buccal nerve as it's coming out of the V3 here, the mandibular division of 5. Okay, also off the mandibular division of 5 is the posterior and anterior deep temporal nerves. These loop right up into to innervate this temporalis muscle. This is for motor control. Also, there's a masseteric branch here that comes out and innervates the masseter for motor innervation. So these will be muscles of mastication here, the masseter and the temporalis. So although the trigeminal is mainly a sensory nerve, there is a motor component within this mandibular division for the muscles of mastication right there. So those two are unique. Let's look at some vasculature now. The maxillary artery. Remember, this is a branch off of the external carotid that once we've removed the mandible, or the ramus rather, we can see this is pretty much exactly what you've done here. You've cut right about here at the ramus, right at the level of the teeth, and dislocated or cut off that condylar process. So we can see this maxillary artery. So remember the middle meningeal artery right here, the first one of those first branches coming off here. This travels through the foramen spinosum within the skull, just behind or lateral to the foramen ovale. It ascends on the inside of the skull within that groove of the bones. Remember you saw that previously? And it will supply the meninges. We talked about this and that it can be involved with a fatal dural bleed. If you get a blow to the side of the head here, that might actually disrupt or compromise that middle meningeal artery. If that happens, that can create an epidural hematoma, and that can be fatal because it will tear the dura and then push right into the brain tissue itself. And if it's not relieved almost immediately, it's a fatal condition. So very dangerous to get those blows to the side of the head there. Off of that maxillary artery as well, we're going to see the superior alveolar arteries right here. There's a anterior, middle, and a posterior superior alveolar arteries. These travel in the back of the maxilla to supply the upper jaw and the upper teeth here. We've seen the inferior alveolar. Here's that inferior alveolar nerve coming off of that mandibular branch. Here's the inferior alveolar artery, one of the first branches off of the maxillary artery, coming down this way. This is traveling into that mandibular foramen with that inferior alveolar nerve to supply nutrition to the lower jaw and the teeth. Let's see here. Off of that the maxillary artery here as well, you can see there's the infraorbital artery. That's this one coming up here. That's going to be a continuation of the maxillary traveling through the well, here you can kind of see that slit there, the inferior the inferior orbital fissure right here. So it kind of sneaks up in that inferior orbital fissure and then down onto the base of the orbit. Kind of lays right on the bottom of the orbit within a groove. Sometimes, though, it can be covered as osseous tissue will cover it, and then it will go through a canal. Ultimately, it will exit in that infraorbital foramen right here. So through the inferior orbital fissure and then exiting the front of the face through the infraorbital foramen to supply blood to that area there. There's the sphenopalatine. You can see it kind of sneaking up here. Here's a better shot of that, the sphenopalatine artery right there. This is kind of a terminal branch of the maxillary artery. This exits, well, it rather enters here, right, at the at the pterygopalatine fossa, which is kind of between the pterygoid process and the palatine bone. So between that, the pterygopalatine fossa, and will supply blood to the nasal cavity. You can see it kind of sneaking up into here, into the nasal cavity. Let's see. We'll look at that more with detail later today as we look at the nasal cavity more. Again, off the maxillary, coming down in that pterygopalatine fossa. Deep here is the descending palatine arteries as they come down, and then you'll see how they enter on the bottom of the palate here, between right at the lateral part of the perpendicular or the maxillary. Boy, I don't know why it's hard for me to say. The palatine processes of the maxilla, and then the horizontal plate of the palatine bone here. There's these two little holes for the greater and lesser palatine arteries and nerves that we'll see in a little bit. But that deep palatine artery will then branch into the into the great palatine artery and the lesser palatine arteries coming back in towards the soft palate. So great palatine going to the hard palate, lesser palatine to the soft palate. Okay. And then the anterior, let's see, come back to this shot, the anterior and posterior deep temporal arteries. These are going to travel with the anterior and posterior deep temporal nerves that we just saw to supply the temporalis musculature. Okay, and then continuing up from the external carotid, that will then, after the maxillary branch takes a hard turn here, the continuation will be the superficial temporal artery, and that's going to be traveling up in front of the ear and supply the side of the skull, right up on the top here. Okay. Let's just review quickly the TMJ, the temporomandibular joint. What I just want you to notice here is that the complexity of this joint. It hinges and glides as it moves, as it opens and closes. As it opens, you can see from a closed position here it's opening, here it's open, and then it's going to close back up. As it opens, what you'll notice is that it hinges down. You can see how it's going to kind of hinge down, but then glide forward. See how it started way back here and then it ended forward from that position. As it closes, it will hinge up and then glide back. So that's interesting. There's a fibrocartilage disc inside of here, and then there's this ligament. The one I want you to really pay attention to is called the lateral ligament. This is commonly involved with pathology, as that might loosen. That could cause that articular disc, that fibrocartilage pad, to tear, might cause some pain or some cracking, some clicking in the jaw. If you've been to the dentist and they put their fingers on your jaw and they've opened and closed and opened and closed, they're kind of feeling for crepitus or noise, joint noise in the TMD there. Okay, now let's talk about bisecting the head here. We've already taken the calvaria off. That was an interesting lab, wasn't it? Where we kind of sawed through right above the supraorbital margin here, back around to the occipital bone, took off that whole calvaria, and basically took off what allowed you to be able to see inside the skull like this, right? Now, we're going to use a hacksaw, again, the larger hacksaws, and we're going to cut mid-sagittally, okay? So the trouble with that is that you're going to have to change the angle of the saw somewhat as you get kind of started on that process because you've only got a few inches between the blade and the top of the hacksaw, and so you can't just keep sawing straight down because you'll get stuck. So you'll have to kind of go from the front a little bit, and then on the back a little bit, and then eventually you'll be able to spread the skull apart to complete the bisection straight down. So it might be best to get the donor in a bit of a sitting position to get the skull more up and down. And we can place blocks behind the shoulder blades to help maintain that position as well. I have a dog with a squeaky toy. I hope that's not annoying, more than me making reference to it at least. Okay, so I think it's best to have one person on the left side of the skull, one person on the right side of the skull, kind of with fingers and grabbing inside of that, the anterior, middle, and posterior cranial fossas here. So to kind of pull apart as another person saws right down the middle. Okay, so one person's going to saw right down the middle, one person's going to be on the left and the right, kind of pulling apart there. And what you're going to try to do is split right down through the nasal bones, right down through the middle of the nasal cavity. You're going to go right down through the middle of the maxilla, and then try to split the incisors right down the middle, and then right down through the ramus of the mandible. Now, you might run into some trouble if the donor has had some dental implants. So this can be difficult to saw through that metal, and we may need to get creative. We may need to kind of jog around that. I don't know what we're going to find until we get in there, but just be mindful that if you are having trouble getting through the incisors here, that may be why. And I'd like you to actually, I'm going to show you a different slide here. I'd like to actually have you go right down through, all the way down. Bring it down to about the level of C6, C7, so right below the larynx here. I want to be able to see a mid-sagittal view of these structures within the larynx. So through the thyroid and cricoid cartilage, and maybe just a little bit more, maybe down to about C7, okay, as you get there. So hopefully that's what we'll be able to see. Now, let's keep talking about structures that we're going to notice as we go through here. The pharynx has three muscles. They're called constrictor muscles, three constrictor muscles. There's a superior right up here. There's a middle group of muscles here, and then there's an inferior. So superior, middle, and inferior constrictor muscles. The superior pharyngeal constrictors come together in the back. All of them really come together right in the back at a midline raphe on the back side. But the superior one arises right off of this pterygomandibular raphe right here, and then comes backwards and together at that midline raphe in the back. And the nasopharynx, the top of the oropharynx, is going to kind of be contained within the back side of that superior pharyngeal constrictor. The middle pharyngeal constrictors coming up here, these are coming off of the hyoid bone. And then they're going to insert at that midline pharyngeal raphe on the backside, just like the superior. And then the inferior raphe, here you can see it comes off of the cricoid and the thyroid cartilages and also inserts at that midline raphe in the back. Pardon me. So together, you can see how the superior, middle, and inferior, these are going to act like they're going to contract in sequence during swallowing. So they're actually going to be kind of this propulsion of the food bolus down towards the esophagus, right? So back of the oropharynx, and then back here, and then down into just in that laryngopharynx, and then right down, shoving that food bolus down into the esophagus. Okay, let's look at this slide here, kind of a cross-section view of what you'll notice in your dissection. And you see right here this internal branch of the superior laryngeal artery. Remember that the larynx is innervated by the vagus nerve, but it's done so three times: twice by the superior laryngeal artery, and once by the inferior or recurrent laryngeal. Remember the internal. Let's go back to this slide maybe. That superior laryngeal branch of the vagus is going to come off here, and it's going to innervate right into the glottis area. That's what you see here coming through. So if we go back to this, here's that internal branch of the superior laryngeal nerve. Here's the external branch coming down, supplying more motor innervation to the cricothyroid muscle right here, which is needed to kind of cock that thyroid cartilage forward to tighten up the vocal cords so you can speak. right there. And then you've got that inferior or recurrent laryngeal nerve coming up from here. Remember that vagus nerve loops, or it sends a loop around the arch of the aorta on the left, or around the common carotid, the subclavian artery on the right, rather, sorry, and then looping up right next to the trachea, and that's going to come up and innervate most of the muscles of the larynx, besides the cricothyroid, which is the external branch of the superior laryngeal. But all of those are basically branches of the vagus. Okay, now the glossopharyngeal nerve, here's glossopharyngeal. You can see it coming out of that jugular, well, you can't really see it coming out of the jugular foramen, but here's glossopharyngeal coming from the jugular foramen coming down. This is also going to be a contributor to sensory and motor innervation to this area as well, right through there. Let's go back to that cross-section view here. Let's go to this cross-section view. The pharynx itself has three parts to it. There's a nasopharynx, an oropharynx, and a laryngopharynx back here. The nasopharynx is behind the nasal cavity. You can see it here. It has respiratory epithelium, because it's mostly going to be respiratory. I hope respiratory, unless you laugh so hard you spit something out your nose. But most of the time that nasopharynx is going to be pseudo-stratified columnar epithelium. And then the soft palate will kind of close up here. We'll talk about some muscles that help close that soft palate up, closing that nasopharynx, not allowing food or drink to come up into the nasal cavity. The oropharynx is going to be basically from the level of the palate down to the level of the hyoid bone, right through here. Okay, that's the oropharynx, the part of the pharynx behind the oral cavity. And the laryngopharynx is going to be basically from that level of the hyoid down below the hyoid, and then behind the larynx. Here's the larynx, the voice box. Here's the epiglottis that would cover that when you swallow, and then above the esophagus. So that's the laryngopharynx here. Naso, oro, and laryngopharynx. You can see, here's just a shot from the back. You can see those constrictor muscles from the back. So they've cut right down, Netter has drawn this as he's cutting right down that midline raphe towards the esophagus. Here's the inferior, here's the middle, and here's the superior, middle, inferior constrictor muscles, just as a different shot of that. Okay, let's talk about the nasal cavity a bit. There's a nasal septum, which equally divides the nasal cavity right and left. Now, if you don't have an equal division left and right, you would have what they call a deviated septum, and that can be surgically corrected if you choose. It's made up, though, bony-wise, of the perpendicular plate of the ethmoid bone right here, which is the majority of the superior portion on the anterior side, and the vomer, which is the majority of the posterior portion on the inferior side here. Those are the facial bones, or the ethmoid is a cranial bone, but the vomer is a facial bone that make up the septum of the nasal cavity. So let's see what else I wanted to say there. Okay, now the lateral wall. Here you can see the septum covered by the epithelium here. The lateral wall, though, of the nasal cavity is made up of nasal concha. So remember we talked about those previously, the superior and middle nasal concha, and then the inferior nasal concha is its own bone, superior and middle being part of the ethmoid bone. They're covered by a mucus to help mucous membrane to kind of help capture any particulates that may be inhaled through the nose. It's also very vascular. We'll see some of the vasculature as we go through today's lecture as well, which is helpful for humidifying the air that's inhaled and also warming it. Under each concha is a space called a meatus. So kind of on the superior portion of that, kind of above or behind that superior nasal concha, you'll see an entrance into the sphenoid sinus. Here's that sphenoid sinus. Remember, the pituitary gland sits in that sella turcica, and then the body of the sphenoid bone is right here, but that's hollow. So that sphenoid sinus, here you can see Netter has actually put a kind of a thread, a wire from the sphenoid sinus into the nasal cavity right there. So that's where the sphenoid sinus will drain into the nasal cavity. There's a middle nasal concha, the middle meatus. You can see how Netter has kind of lifted this up and then cut it. You can see how that's been cut here. And here you can see a few things. Now, what you'll notice here is a semilunar hiatus, which is kind of this little depression right here. It's underneath what we call this bulge called the ethmoid bulla, which is just part of the ethmoid bone here. At the top of that, what you'll see is the entrance to the frontal sinus. So there's the frontal sinus here, and it travels down through this canal. There's what's called the frontonasal duct, which connects the frontal sinus to just in that middle meatus right here, underneath the middle nasal concha, and that empties right next to that, right at the front edge of that semilunar hiatus and the ethmoid bulla there. Also of note in this area, at the bottom of that ethmoid bulla here, at the bottom of that semilunar hiatus is an opening for the maxillary sinus. This might be larger if the donor you're working with here has had surgery done to this area. This is going to just go right into the ethmoid sinus, which is just right underneath the orbit. So you might be able to kind of break through or kind of put a probe right through that into the maxillary sinus, which is right there. And then the ethmoid air cells. Now here you can see these are just those, remember those honeycombed, they're hollow, kind of in the lateral wall. The ethmoid air cells might be right into there as well. You should be able to see kind of this middle and anterior ethmoid air cell entrances in that ethmoid bulla right through there. All right, now the inferior nasal concha, you can see how that's been cut here as well. This is going to have an opening to the nasolacrimal duct. Remember this from the tears being formed here. This is going to come from the lacrimal gland on the outside of the superior portion of the socket. It's going to drain across the eye, and anything that doesn't drip over the inferior eyelid is going to come down. It's going to drain, remember, through the puncta of the eye, into the papillae, into the canaliculi, eventually into the nasolacrimal sac, which then will go into the nasolacrimal duct, and guess where that enters the nasal cavity? Right underneath the inferior nasal concha, right here. So this is why when you cry heavily, you're going to get a runny nose. That's going to come down. That draining is going to come down right into the this portion of the nasal cavity. Okay. Also, kind of right in the back side of that inferior nasal concha is the entrance of you can see this kind of pharyngeal opening of the eustachian or the pharyngotympanic, or often called the auditory tube, coming into that middle ear cavity. That's going to be right there. And that's why you can sometimes use yawning or kind of pressure through the nasal cavity to unplug your ears. If you're in a car ride going up a big hill, or in an airplane that's taking off or landing, yawning, you can decrease, you can kind of release that pressure from the middle ear cavity through the nasal cavity, right in the back side here towards that nasal pharynx. On the top side of that is these pharyngeal tonsils, the adenoids, they're often called, right up on here, kind of around the top of the nasal pharynx. These can sometimes get so enlarged that they occlude the pharyngeal opening of the auditory tube, and that can cause an increased incidence of middle ear infections. Around the outside of that, the kind of surrounding this, there's a bulge of tissue here. There's a cartilage base, and we'll learn some muscles that come from that in just a few minutes here. But kind of surrounding the pharyngeal opening of the auditory tube, they call that the torus tuberous. Torus means bulge, and tuberous referring to the tube, the auditory tube. So bulge around the auditory tube is right in back of the nasopharynx, right behind the inferior nasal concha there. Okay, let's now look at some of those muscles that we were just alluding to. from this view here. Now this is looking from inside the mouth. This is a cross section. This is what you're going to be looking at today, hopefully. Inferior, middle, and superior nasal concha, nasopharynx. Here's torus tuberous, the pharyngeal opening of the auditory tube, the adenoids up on top. Let's look at these some of the musculature here now. The Vili Palatini brothers here. There's two muscles I want you to know here. The levator Vili Palatini, which is going to come from that right underneath the opening of the eustachian tube, right there, the levator Vili Palatini. These are going to start to lift and tighten up, excuse me, the soft palate here during swallowing. So levator is going to lift it, and then tensor Vili Palatini is going to tense that, kind of come around. It's going to hook around on each side. It's going to hook around through a little sling, a hook called the hamulus of the pterygoid bone, the pterygoid process of the sphenoid. And it's going to hook around here and attach to the soft palate as well. So the levator is going to lift it, and the tensor Vili Palatini is going to tighten it up and really hold that soft palate tight. And together they'll keep that opening to the nasopharynx closed during swallowing. Okay, a couple other muscles here. There's one here called the palatoglossus, from the soft palate and the kind of that junction of the hard palate down to the tongue. Palatoglossus here. And then there's one, this is going to help elevate the tongue during swallowing. So as you swallow, you'll lift up here. This will, levator Vili Palatini will help lift that soft palate up, and that helps kind of close off that soft palate. You can see this bundle right there, that palatoglossus. Here you can also see it covered by the skin, the fascia of the oral cavity. This is going to make up the anterior tonsillar pillar. When you look in somebody's mouth, when you look at their tonsils, their palatine tonsils here, there's an anterior pillar and a posterior pillar, and the tonsillar bed sits right in between those, which is where this palatine tonsil sits. The posterior pillar is made up from this muscle here called the palatopharyngeus, right down here. So from the palate again, from the hard palate and the soft palate coming down, and then it's going to attach down into the upper posterior kind of boundary of the thyroid cartilage in the back here. So from the palate to the thyroid cartilage, back to the pharynx. So palatopharyngeus, named for where it comes from and where it goes to. Palatoglossus, glossus is tongue. Palatoglossus, palatopharyngeus. And that's going to help pull the pharynx up during swallowing. So palatoglossus pulls the tongue up. Palatopharyngeus pulls the pharynx up. Helps prepare the swallowing activity there. And that's also going to make up this posterior tonsillar pillar right here. So again, the palatine tonsils sit right between the anterior and the posterior tonsillar pillars. Here you can also see sneaking through between the palatoglossus and palatopharyngeus is the glossopharyngeal nerve, cranial nerve number 9 again, coming right here, entering kind of into the posterior part of the tongue, will provide sensation to the throat and innervate a couple of muscles for swallowing there. Also provides taste to the posterior 2/3 of the tongue, that bitter taste back here. Okay, let's look just for a second at the back of the throat again. You can see we've basically just cut off the back of the constrictor muscles to take a look at this. Here's the esophagus. We've opened up the proximal part of the esophagus. Here's the trachea in front of that. Here's the epiglottis covering the glottis to the larynx, which would sit right in front here. But there's these spaces here. This is interesting. This piriform fossa, or the piriform recess, is on either side of the larynx within the laryngopharynx, right back in here. And this is a spot that's just kind of funny, because you can sometimes people will talk about getting pills or pieces of food stuck back in here into that piriform fossa, or the piriform recess, but that's where that would be right here. So as you've cut right through, maybe you can identify that piriform recess back there. Let's talk about the tongue a little bit now. The tongue is covered with these filiform papillae. These cover the whole tongue. It gives it its texture so we can move food and such around on our tongue with ease right through there. Then there's fungiform papillae, which are a little bit larger bumps. The Greeks thought they looked like mushrooms, so they called them fungiform. And then there are circumvallate papillae. These are the big ones in the back here. They make kind of an inverted V in their orientation. They're much more prominent, the circumvallate. Circum means surrounded by, vallate means moat. Maybe they thought that looked like they were surrounded by a moat because they do kind of have that inverted V shape to them. These are going to be much more sensitive to the bitter taste. There's one theory I've heard that, bitter is in the back of the tongue because that's where the gag reflex is. So we want to get rid of things that might taste bitter to us. I'm not sure if that's true or not, but probably shouldn't have added that to this lecture. Anyway, in this shot, you can also see this strand right here connecting the back of the tongue to the front of the epiglottis. This is the median, the glossoepiglottic fold. Glosso, tongue, epiglottis, epiglottic fold here. So the median glossoepiglottic fold between the tongue and the epiglottis. This was helping to limit the movement of the epiglottis. You're still able to close it during swallowing as the larynx is kind of lifted up, but it doesn't want it to just kind of flap down all the time. Okay, and let's see. Also, you can't really see it on here, but there's these on the back side, the palatine tonsils. We've seen those already from the anterior and posterior pillars, and then we saw the adenoids, the pharyngeal tonsils, and then the lingual tonsils are in the back of the tongue here, the base of the tongue. These are again immune tissue, lymphatic tissue that helps respond to foreign antigens that enter the oral cavity. So if I go back to here, you can really see how the pharyngeal tonsils, the palatine tonsils, and the lingual tonsils, really anything being inhaled or entering the nasal or oral cavities, it's got a pretty good line of defense right away. So if your tonsils are working well, they'll be able to kind of capture any antigens before they come into your system through those other means. Okay, how are we doing? Let's get my bearings here and figure out where we're going. I guess let's talk about the bottom, the muscles of the bottom of the oral cavity. We've touched on these a little bit already. Mylohyoid right here. You can see the mylohyoid from the ridge on the inside of the mandible. It's going to come down and around. It's going to insert onto the hyoid bone from each side, and then it connects to itself on each side at a midline raphe on the median, kind of the midline there. The digastric muscle here, you can see it is kind of this far one here coming from the mastoid process, coming through a loop on the hyoid bone, this fascial loop, and then coming up and attaching onto the front of the mandible here as well. Here's a different shot of it here. I didn't notice this. So here's the mastoid process from the side view. Here's a digastric, the posterior belly. You can see how it's going to kind of loop through this fibrous sling here on the hyoid and then come up and attach on the front of the mandible there, the anterior belly. So posterior and anterior bellies. Remember, the posterior belly innervated by the facial nerve, anterior belly innervated by the nerve to the mylohyoid, which is that branch off of the inferior alveolar off of V3, the mandibular division of 5. Got all that? Okay, and then let's see, what else do we have here? The stylohyoid, here from the styloid process down to the hyoid bone as well. There's that. And then on the inside, so here's on the outside, let's look on the inside of the mouth. Underneath here, you've got the geniohyoid. This is going to come from little bumps on the inside of the mandible called the genial tubercles and attach back to the hyoid here. This is all in the bottom of the oral cavity. Okay. Let's talk about the, we'll finish here talking about the nasal cavity. And the floor of the nasal cavity is these bony plates here. So remember the palatine processes of the maxillary bones as they come together right here. The horizontal plates of the palatine bones. This makes up the hard palate. Both of those make up the hard palate. And then the vomer, which is the kind of that inferior portion of the nasal septum attached kind of to the back of the palatine bones. Here on the front between the two maxillary bones is this incisive foramen going to a canal kind of right behind the upper incisors. And then on the back here, we've alluded to this previously, but here's that greater, and then there's two lesser palatine foramina. And these are kind of at that lateral aspect of the horizontal plates of the palatine bone. This is where the entrance of the greater and lesser palatine arteries from the descending palatine artery. Remember, we saw that previously. We'll see it again in a minute. And the greater and lesser palatine nerves off of the maxillary branch of trigeminal are going to come through there, innervating the hard and soft palate. Now, I just want to show this part here quick as well, because don't forget the olfactory portion. So the olfactory nerve here, these bipolar neurons are going to come up for the sense of smell. They're coming right up from the top of that superior nasal concha, and they're going to go through the cribriform plate and innervate the olfactory bulb, which sits right over the olfactory plate. The cribriform plate, cribriform plate of the ethmoid bone, but that's where the olfactory bulb is going to sit, where they're going to stimulate the cranial nerve number 1 for the sense of smell. Okay, now let's see here. How do I want to go through this? So we talked about, I'm going to go back to this slide, I think. This might get a little confusing. I apologize in advance. Remember this? We saw these anterior, here's the anterior and posterior ethmoidal foramina. This is kind of right in that orbit by the perpendicular plate of the ethmoid and the frontal bone, right up into here. This is the entrance of the anterior and posterior ethmoidal artery and nerve. The artery is gonna come kind of, and nerve are going to come through here. They're going to come over that cribriform plate and then dive down into that nasal cavity. Branches of the anterior ethmoidal nerve, if I go back to this shot now, are going to come down here through that cribriform plate. They're going to come down into the nasal cavity. And they're going to provide sensation to the anterior portion of the septum and the anterior portion and the dorsum of the nose, kind of coming up from this way. And then the posterior branches are going to kind of get lost right in the picture here, right in the back where the olfactory area is here. Now this picture, you might be looking at this. This took me a while to understand myself, this particular picture, but this is actually, Netter has drawn this as the right side of the nostril. Here is the nasal septum on the right nostril, and here is the lateral border of the nasal cavity. So he's drawn even a hinge in here, this fabricated hinge right here. So imagine this kind of closing down and being the right nostril. So, oh boy, this might be too much here. But if I go back to this picture right here, this is what we're looking at. He's just lifted this up. Does that make sense? I hope that makes sense. Let me go back to this one. So he's just lifted that up. So you can see that inside of the septum here, this is not the brain or the frontal bone. This isn't going up. Here's the orbit. We're not going up into that. He's hinged up the septum here. So here you can see the lateral and the medial border of the nasal cavity on the right nostril. Hope that makes sense. So let's take a look here and see some of this. Now, the big nerve here I just think is important to notice right off the bat here is this pterygopalatine ganglion right here, and you can find this in it's found housed within that pterygopalatine fossa right here. There's the parasympathetic ganglion, and you can find this right in the back of the nasal meatus. If you go straight back from there, and if you wanted to, I would encourage you to take a blunt probe. The bone is very thin here, and just kind of punch through this a little bit, kind of break through it with the blunt probe. You can take some forceps and remove some of those pieces as well, that cracked bone, and see if you can find and expose this pterygopalatine ganglia. Okay, now off of that, we're going to see a few things. If we go from there, it's going to, now again, this is on the septum, which is going to be on the kind of facing the screen here, but here he's hinged it up. So here's this nasopalatine nerve, which is off of the maxillary branch of the trigeminal nerve. This travels down the medial side of the nasal cavity, right down the septum, and then exits through the incisive canal. And here you can see where that would be on this other part of if the hinge were down here, that's where it would be, this incisive canal. Remember, between the two palatine plate processes of the maxilla. And that's going to then come down and enter into the palate a little bit right into here. We're not really sure why the palate is well innervated by the greater palatine nerves here, but that comes down there. So it seems to work pretty well. I have no reason to question your designer in that, but it seems kind of weird that the nasopalatine would go through the septum, through the incisive canal here and here, and then come down onto the palate. But anyway. Okay, now the greater palatine nerve, you can see coming down here, this is going to come down and provide a couple of branches. This is, it's going to, well, actually right off of the ganglia is going to be this posterior superior lateral branch on the coming up into the lateral side of the nasal cavity. And then off of the greater palatine nerve, you've got this posterior inferior lateral branch coming down more on the inferior nasal concha. And that's going to provide sensation to those areas there. Let's see here. What else do I want to talk about? That might be it. And then here we can see where that anterior ethmoidal and the posterior ethmoidal branches are going to come and provide a little bit of the sensation on the septum here, and then into the nasal and the dorsum of the nose and the lateral wall, and then same thing on that posterior ethmoidal nerve is going to come down here through the posterior ethmoidal foramina. Okay, let's look at some of the vasculature now. Let's just finish maybe up with this one here, the sphenopalatine artery. Remember that one? Sphenopalatine artery came up and then hooked into it goes through the sphenopalatine foramina right here, which is a branch of the maxillary artery. It's going to enter the nasal cavity though, and that same kind of hinge here, so you can see how the septum is lifted up here. It's going to come through, it's going to give a posterior septal branch right here. Posterior septal branch on the posterior septum, and then that's also going to exit right into that incisive canal and then come down and enter in and kind of supply some of the blood supply and meet up with the blood supply from the greater palatine artery off of the descending palatine artery here. Coming down that way. And then you've got the posterior lateral branches. Here's the posterior lateral branches coming off of that sphenopalatine artery, supplying the concha, mostly traveling into the concha back to front this way. Now remember, there was that ophthalmic artery way back when we talked about the eyeball, and that's where we got introduced to that anterior and posterior ethmoidal branches of the artery. So this is going to be off of the internal carotid. Supplying the orbit was that ophthalmic artery, and then off that ophthalmic gave the posterior and anterior ethmoidal arteries, and they went up. Remember we talked about they went through the anterior and posterior ethmoidal foramina into the cribriform plate and then down into the nasal cavity. Now we see them here. Okay, so that's what we're looking at. The anterior ethmoidal artery is going to supply the front of the septum, or up in here, and the dorsum of the nose coming down this way. Then there's anterior lateral nasal branches and anterior septal branches. Anterior lateral nasal and anterior septal branches right here. Okay, and then you've got the posterior ethmoidal, which is also going to supply the top of the nasal cavity, but it's going to have these lateral branches onto the lateral aspect here where the concha are, as well as septal branches coming up this way. Whew, I hope that was not too much, but that's probably enough for tonight. I appreciate you paying attention and listening so well. I trust that that's what happened, and I hope this was helpful. Hopefully you learned something as always, and I will look forward to doing this dissection with you in lab. Thank you for your time. Hope you have a great rest of the day.